This chapter will deal with the alimentary canal. This is where digestion and absorption of nutrients occur. We will cover the esophagus, stomach, and intestines. Together, these are referred to as the GI tract. First, we will look at expulsion from the GI tract. Expulsion indicates either irritation or a malfunction. Expulsion typically is not serious if it is of short duration, but can result in serious systemic consequences if it is prolonged. The first example of expulsion is vomiting. Vomiting is initiated by the vomiting center found in the medulla oblongata. This receives input from another part of the brain called the chemoreceptor trigger zone. Vomiting can be stimulated by circulating chemicals or therapeutic drugs. Circulating chemicals result from damaged tissues, especially from bacterial infections or through radiation. Both circulating chemicals and therapeutic drugs act by stimulating the chemoreceptor trigger zone, which then stimulates the vomiting center. Vomiting can also be stimulated due to central nervous system disorders. These include things such as meningitis, cerebral ischemia, and intracranial pressure. Vomiting can also be stimulated due to inner ear problems as well as psychological disturbances. Complications of chronic vomiting include loss of fluid that can result in dehydration, loss of electrolytes that can result in electrolyte imbalances, loss of vitamins that can result in various deficiencies. It can also cause bleeding due to tears in the mucosa. This would be the result of violent vomiting. And a further complication would be aspiration of the vomitus. This can occur if one vomits while being unconscious. The vomitus can then block the respiratory passages, resulting in asphyxiation. Vomiting begins when the vomiting center is stimulated. This results in pallor and an increase in salivary secretions. Peristaltic contractions will then stop and the pyloric sphincter will close. This is the opening between the stomach and the duodenum. The glottis will also close. This cuts off access to the airways. Now there is only one path for expulsion. The abdominal wall will then begin to contract, as well as the diaphragm and the intercostal muscles. This will cause an increase in gastric pressure, which results in the vomitus being expelled. This illustrates the pathway. Vomiting can result from either memory, sight, or aroma that will stimulate the vomiting center directly, as well as various GI tract stimuli that will stimulate the vomiting center directly. It can be due to circulating therapeutic drugs or circulating chemicals that stimulate the chemotactic trigger zone, which then stimulate the vomiting center. Once the vomiting center has been stimulated, this causes the glottis to close, causes increased salivary secretions. You then have increased contractions of the abdominal wall and gastric wall, leading to increased gastric pressure, which causes the vomitus to be expelled. Diarrhea is another form of expulsion. Diarrhea can be either due to an increased fecal fluidity, an increased volume of feces, or an increase in the frequency of defecation. The basic cause of diarrhea is an increased amount of fluid volume in the colon. This causes distension, which then activates the defecation reflex. There are three mechanisms that can result in an increased fluid volume. The first of these is secretion. Water will be secreted into the intestinal lumen as a response to GI irritation. What are some of the causes of this irritation? It might be bacterial toxins, especially from either the bacteria Vibrio cholera or the bacteria E. coli. Irritation can also be due to laxatives as well as unabsorbed fatty acids. For these first three, bacterial toxins, laxatives, and unabsorbed fatty acids, the increased movement of fluids into the lumen might actually be a benefit. This would act to dilute the irritants and help to eliminate them. Another cause of irritation could be ileum resection. This results in one not being able to reabsorb bile salts, and then this increased salts in the lumen causes irritation and an increased secretion of fluids. And a final source of irritation could be GI tumors. The second mechanism for diarrhea or increased fluids is osmosis. Here, water flows into the lumen in response to high luminal osmotic pressure. This is due to an increased particle concentration in the lumen. What can cause this increased particle concentration? One cause might be faulty digestion. This could be due to a lack of bile or the enzymes necessary for proper digestion. It could also be due to impaired particle digestion. It could be due to an increased uptake of materials that are difficult for one to digest. This could include an increased intake of legumes or beans, or an increase in carbohydrate intake. It could be due to slower intestinal motility. This will favor the growth of bacteria. Bacteria end up metabolizing the nutrients, producing waste products that then will increase the osmotic pressure. Lastly, it could be due to antacid therapy. Some antacids contain increased amounts of magnesium. Magnesium is very poorly absorbed and can cause an increase in osmotic pressure. The third mechanism is impaired water absorption. This could be due to various diseases that act to reduce the mucosa's permeability to water. This will then prevent or slow down water absorption. We will discuss some of these diseases later on. Normally, we must be able to absorb over 8.5 liters of water per day. Other causes of impaired water absorption may be alcohol consumption, therapeutic drugs, and laxatives. And actually, these last three can act by all three of the mechanisms we have discussed. This flowchart shows the factors that can contribute to diarrhea. Various toxins, fatty acids, bile salts, laxatives, and tumor can cause GI irritation to the wall of the GI tract, causing increased fluids to be secreted into the lumen. You can have various GI disorders, causing a reduction in water absorption, causing increased fluids. Faulty digestion or other GI disorders, resulting in increased particles in the lumen. This increases the osmotic pressure, drawing water in. All of this will then result in distension, increased frequency, and diarrhea. The consequences of diarrhea are most threatening to the very young, the elderly, or to those in a weakened state. These include water loss that can result in dehydration, and bicarbonate loss that can result in acidosis. The consequences of diarrhea usually resolve themselves without intervention. However, if it is chronic or severe, one might prescribe either loperamide or paregoric to help. Irritable bowel syndrome is included with diarrhea. This is also known as spastic colon or mucus colitis. Symptoms of irritable bowel syndrome include abdominal discomfort, mainly in the form of cramping, fatigue, tachycardia, constipation, pain radiating down the left arm, diarrhea. Here it is often seen as an increase in frequency and not volume. And finally, an increased mucus content in the stool. The causes of the diarrhea tend to be an increase in intestinal motility. This results in less time for fluid to be absorbed. What causes this? We're not really sure. It may be neurological that causes an increased motility, or it may be a psychological problem. Irritable bowel syndrome is seen oftentimes in people who are described as being driven. Next, we will look at gastrointestinal inflammation. This is usually the result of local injury or irritation. Problems occur as the result of the healing that occurs. One may develop fibroses in the submucosa that ultimately lead to a narrowing of the lumen. This will impede motility as well as obstruct the passage. First type of inflammation is esophagitis. Damage to the esophagus most often is due to reflux of the gastric contents into the esophagus. The acidity of the gastric juice causes the irritation. The esophagus lacks the adaptations that are needed to be able to tolerate the acids. This reflux results in what's known as reflux esophagitis. One will experience epigastric pain, which is a dull, burning ache, more commonly known as heartburn. Reflux esophagitis results due to lower tension in the region of the lower esophageal sphincter. This will allow regurgitation of the chyme, which is the acidic contents of the stomach, up into the esophagus. It can also be caused by the ingestion of chocolate, fats, alcohol, and also through smoking. Reflux esophagitis is also very common during pregnancy and in obesity states. This is due to the increased abdominal pressure that is experienced in both of these. It could also be due to a hiatal hernia. This is what is pictured here at the bottom of the slide. A hiatal hernia occurs when part of the stomach herniates into the thoracic cavity. This can also cause the gastric contents to reflux. The stomach will herniate through an enlarged or loosened esophageal hiatus. The esophageal hiatus is the opening in the diaphragm where the esophagus passes through. Some other causes of esophagitis could be infection, radiation treatment, or the ingestion of corrosive liquids. Inflammation of the stomach and intestines can occur in two forms. The first is mild inflammation. Common terms that describe this include gastritis, enteritis, gastroenteritis, enterocolitis, or colitis. Mild inflammation is often due to ingested biological or chemical irritants. The damage here is often minimal and healing is usually rapid. The other form is acute erosive gastritis. This is due to the chronic use of alcohol, aspirin, or NSAIDs. This can result in bleeding erosions of the mucosa. Appendicitis is inflammation of the appendix. The appendix is a vestigial organ that hangs off the cecum and is made up of lymphatic tissue. We are unsure of its true function, other than the fact that it is a common site of inflammation, especially in those between the ages of 10 and 30. Appendicitis develops when the lumen of the appendix becomes obstructive. This may be due to a fecal lift, which is a hardened mass of fecal material. It could also be due to any type of external compression. When the lumen becomes obstructive, this is going to favor the growth of bacteria. As the bacteria grow, this results in mucosal irritation. This irritation can result in acute inflammation, causing anorexia, pain, and vomiting. As the appendix swells, it can also result in compressing veins, which can lead to ischemia and hypoxia. This will then favor the growth of anaerobic bacteria that live on necrotic tissue. These bacteria then end up producing gas and toxins. Problems occur when the appendix ruptures and release these toxins into the abdominal cavity. This shows the pathogenesis of appendicitis. It can begin due to either a fecal lift or external compression that obstructs the lumen of the appendix. This favors bacterial growth, causing inflammation. The inflammation can result in anorexia, pain, and vomiting, as well as swelling of the appendix, which can compress various vessels, leading to ischemia and necrosis. The next type of inflammation is peritonitis. This is inflammation of the peritoneum. This could be due to an perforation of an inflamed abdominal organ, such as the appendix. It could be due to abdominal wounds, surgery or trauma, bleeding from the GI tract, or perforation of the colon wall due to a tumor. Symptoms include acute onset of pain, fever, and vomiting. Together, these three symptoms are known as acute abdomen. These same symptoms are common with acute appendicitis, cholecystitis, which is inflammation of the gallbladder, GI wall perforation, as well as many other conditions. Peritonitis develops typically where the peritoneum overlays an inflamed abdominal organ, and then where it overlays an inflamed abdominal organ, it too will become inflamed. You then see the production of a fibrous exudate. This is a fibrin mesh that walls off the inflamed area. If this exudate is slow in clearing, it can result in the formation of abscesses. Adhesions often occur due to the post-inflammatory scarring. These adhesions will compromise intestinal motility. One can also develop fistulas. This is a fibrosis that joins two adjacent organs, and then once they are joined, a passage will form between their normally separated lumen. This is a complication of colon perforation, followed by abscesses, and then perforation of the wall of an adjacent pelvic structure. Fistulas present major problems. For example, think about it. If the colon now becomes connected to the urinary bladder, to the small intestines, or even to the vagina, materials that would normally once be confined to the colon now can be exposed to other areas such as the bladder and the vagina. This can cause irritation and infection. Finally, a generalized peritonitis can occur. This is when inflammation does not remain localized. Remember the large surface area that the peritoneum compromises or consists of. This can result in systemic complications. Another type of inflammation is diverticulitis. A diverticulum is a pouch-like sac of the intestinal mucosa that protrudes through the wall of the large intestines. 95% of diverticulum form in the sigmoid colon. Most diverticulum are asymptomatic, but they can cause cramping, discomfort, and constipation. A diverticulum is formed due to increased intraluminal pressure. A pouch will form at a weak spot in the wall. Increased pressure may be due to a low residue diet that produces smaller, drier stools that need a more forceful contraction in order to eliminate them. Two other terms include diverticulosis. This refers to the presence of a diverticula, and diverticulitis, which means irritation and bacterial damage to the wall of a diverticulum. This could be due to impacted fecal matter. Symptoms of diverticulitis include lower left quadrant abdominal pain, fever, diarrhea, constipation, or a combination of both diarrhea and constipation. Problems occur when necrosis of the wall of the diverticulum results. This can cause perforation. The colon contents will then spill out, resulting in peritonitis and possible fistula formation. Successive bouts of diverticulitis can lead to stenosis of the colon, causing obstruction of the passage of materials. Next is inflammatory bowel disease. This includes two conditions with certain common underlying features. These conditions are Crohn's disease and ulcerative colitis. In both conditions, there is no known cause, but we do see a strong pattern of familial incidence. In both, one will experience abdominal cramping, diarrhea, and fever. Both tend to hit mainly whites of European background between the ages of 20 and 40. Looking at Crohn's disease first, you typically will see granuloma formation causing mucosal swelling and erosion. This is due to the chronic inflammation. The lesions tend to affect the mucosa with wall penetration. The lesions will affect either the small intestine or the colon, but may actually infect both areas. Adjacent areas often remain uninvolved. Crohn's produces penetrating ulcers that exhibit a linear pattern. The onset of symptoms tends to be very low level and slow to develop. The symptoms will include pain and discomfort, followed by periods of remission. Chronic recurrence can lead to weight loss and anemia. This would be due to a lack of iron and B12 absorption. Blood in the stool is uncommon in Crohn's disease, and only about 1% progress to cancer. In ulcerative colitis, the inflammation produces no granulomas. The lesions tend to be confined to the mucosa of only the colon. The onset of symptoms can be gradual or acute. And ulcerative colitis tends to produce superficial ulcerations with a very irregular pattern, and they are very diffuse. Symptoms of ulcerative colitis include blood in the stools, abdominal pain and diarrhea, fluid and electrolyte loss, hemorrhage, which can lead to hypovolemic shock, anemia. About 8% of ulcerative colitis are associated with cancer, and lastly, ulcerative colitis has about a 15% mortality rate. Complications of both disorders include possible peritonitis and fistula formation. You can also see intestinal stricture due to scarring. This complication is more commonly seen in Crohn's disease. You can also see various systemic effects. These include eye and joint inflammation, liver damage, and cancer. Therapy includes the use of antidiarrheal drugs to help ease the symptoms, anti-inflammatory drugs to help limit the disease, and bowel resection in more severe cases or in the case of cancer. Many times, however, even with a bowel resection, the disease can reoccur in a previously unaffected segment. Next, we'll look at ulceration. Remember that digestion involves very harsh enzymes and potent chemicals. The stomach and the small intestines have various protective mechanisms to protect itself against these enzymes. These protective mechanisms include a thick mucus blanket that contains proteins and bicarbonate ions to help decrease the acidity. The epithelial cells are joined by tight junctions. This will prevent the diffusion of the hydrogen ions or the acidity into the submucosa. And lastly, we continually slough off the epithelial cells. Old and damaged cells will be lost and replaced with new ones. On an average of every 5 to 6 days, the entire lining of your small intestines will be replaced. If something happens to any of these defenses, the surface epithelial cells will become overwhelmed, and the subepithelial tissues will now be exposed to the harsh acids. These acids will digest the area as if it were another food source, and this is what results in an ulcer. One type of ulcer is a peptic ulcer. This is caused by pepsin. Pepsin is the major protein digesting enzyme. Traits of a peptic ulcer: they may occur throughout the esophagus, stomach, and small intestines. About 98% of them occur in the stomach and the duodenum. Most occur as a single ulcer, and the size is on average between 1 and 3 centimeters, and they tend to have a very smooth margin. There are 2 common etiologies for peptic ulcers. The first is gastric hypersecretion. This is the overproduction of acids. This may be due to hyperplasia of the parietal cells or the chief cells. The parietal cells are the ones that produce the acid, and the chief cells are the ones that produce the pepsin. Gastric hypersecretion may also be due to an excessive production of acids due to a normal stimulus. The stimulus is normal, but the cells are hyperacting or overreacting to that stimulus. It could also be due to an increased gastric wall motility. This causes an increased exposure of the duodenum to the gastric juices because of this increased gastric emptying. Lastly, smoking can cause an increase in secretions. However, we're not quite sure as to how this occurs. The second etiology is an impairment to our defenses. One thing that can impair our defenses is an infection with the bacteria H. pylori. This is a very common cause of peptic ulcers. One has an infection by H. pylori, and this leads to the development of an ulcer. NSAIDs, such as aspirin and indomethacin, can cause damage and bleeding to the gastric and duodenal mucosa. This results in exposing the deeper layers to acids and pepsin. NSAIDs also inhibit prostaglandins. Prostaglandins help to stimulate mucus secretion. So, in other words, what they're doing, the NSAIDs are compromising our defenses by preventing the production of this protective mucus. Genetics can also cause impaired defenses. Genetic disorders can result in hyperplasia of the parietal and chief cells, as well as a reduction in our other defense mechanisms. Smoking can also compromise our defenses. Smoking causes a decrease in blood flow, as well as a decrease in the production of prostaglandins. The incidence of ulcers tends to be more common in adult males in industrialized Western nations with a family history. Usually they appear middle age and beyond. There is also an increased incidence of peptic ulcers associated with hepatic cirrhosis, obstructive lung disease, and rheumatoid arthritis. An uncomplicated disease is when an ulcer appears in patients who are otherwise normal. This condition tends to be chronic with various recurring episodes. Many of these often resolve themselves and heal with no complications. Symptoms of peptic ulcer include periods of burning pain in the abdomen. The effect of food will determine where the ulcer is. If the ulcer is in the duodenum, the pain will begin about 30 to 45 minutes after the meal, but taking in more food will bring relief. What happens is that the initial eating will produce an increase in gastric secretions, and this is what causes the pain. By eating later on, this absorbs these secretions and will bring relief. If the ulcer is a gastric ulcer, this will result in anorexia, vomiting, and weight loss. Here, eating will actually aggravate the symptoms. Complications of peptic ulcers occur in about 20% of all cases. This includes bleeding if the ulcer penetrates deeply and erodes an artery wall. About 10% of these will be fatal. Another complication is perforation of the stomach or the duodenal wall. This can lead to peritonitis as well as pancreatitis if the pancreas is involved. Another complication is gastric obstruction. This usually occurs in the area of the pylorus. This will cause muscle spasms or hypertrophy, and it's actually the healing of the ulcer that will cause the obstruction. This is showing the various pathogenesis, different genetic disorders, H. pylori, NSAIDs use, smoking, and how each of these will either cause an increase or cause a compromise in our defenses or an increased production of acids leading to ulceration. Therapy includes changing your diet. One should eat anything that doesn't aggravate the pain. Usually this involves things that don't promote acid secretions. One should also try to avoid caffeine as well as NSAIDs. Therapy also involves reducing the acid levels and trying to promote healing. This can be done through the use of antacids. They will neutralize the existing acids. One can also take H2 blockers. These are things such as Pepcid and Zantac. These are special antihistamine drugs that will suppress acid secretions by interfering with the normal histamine stimulus to the parietal cells. If you inhibit the parietal cells, this will decrease the gastric acidity. Surgery can be done in severe cases. This involves section of the vagus nerve, which will limit the central nervous system stimulus. This will decrease the stimulation that causes acid production. Another type of ulcer is a stress ulcer. These are usually gastric ulcers. They will show up as multiple smaller peptic ulcers. They can be due to acute systemic stress, trauma, such as accidents, central nervous system damage, skin burns. Could be due to a serious illness, such as a bacterial infection that spreads through the blood, or it could be due to cardiovascular shock. The mechanism of developing a stress ulcer involves hypersecretion of gastric juices. This is easy to see how it occurs, especially if the problem is a central nervous system injury. This can result in an increased stimulus to the stomach, causing increased acid production. Another mechanism is mucosal ischemia. This is from vasoconstriction or hypotension due to cardiovascular shock. This weakens the mucosa, and once the mucosa is weak, it becomes more susceptible to the gastric acids. Most cases of stress ulcers are asymptomatic and cause only minor difficulties. Next, we will look at gastrointestinal bleeding. This is usually identified by the presence of blood in either the feces or the vomitus. The term hematemesis refers to vomiting of blood. Sources of bleeding in the upper GI tract may be due to gastric peptic ulceration or duodenal peptic ulcers. It could also be due to laceration of the gastroesophageal junction, esophageal bleeding, gastritis, or tumors. Melena occurs when blood spends time in the stomach before it has been vomited. When blood is in the stomach, the enzymes will begin to alter it so that now it looks like coffee grounds. Blood lost directly into the small intestines will result in the production of dark tar-like stools. This is usually seen with peptic ulcers. Bleeding from the colon wall will show as bright red blood in the stool. When blood is released directly into the colon, it is not altered by the presence of acid, so it will stay bright red in color. Bleeding from the colon could be due to diverticulitis, tumors, benign polyps, or inflammatory bowel disease. Determining the source of the bleeding is oftentimes difficult. One needs to look at both the stool and the vomitus for color. Long-term bleeding of small amounts may go undetected, especially by casual observation. This is why it's necessary to look for occult blood, also known as hidden blood. This must be confirmed through laboratory analysis of the stool. Therapy is usually not necessary. If the bleeding is acute or severe, one should replace the fluids. It is often better to treat the underlying cause of the bleeding than the actual bleeding itself. Next, we will look at malabsorption. This is an inadequate absorption of nutrients due to three major defects. It could be due to a defect of digestion, a defect of absorption, or a defect of transit from the intestinal mucosa. Defective digestion may be due to a lack of pancreatic enzymes or to a lack of bile. This is seen in severe pancreas or liver failure. It could also be due to obstruction of bile or pancreatic ducts so that the enzymes are not even reaching the duodenum. It could be due to a surgical resection of the ileum. This will result in a bile insufficiency. The ileum is where the bile salts are reabsorbed to be recycled by the liver. It could also be due to bacterial overgrowth in the small intestines. What happens is that the bacteria end up altering the bile salts so they cannot be recycled properly, and this will lead to a bile insufficiency. It may be due to obstruction. This will interfere with the normal intestinal movement. It could be due to resection of a portion of the stomach or small intestines. This results in a loss of their normal contribution to digestion. And finally, it could be due to bacterial metabolism. This will cause an increase in the osmolarity of the lumen, causing water to enter, and this will produce diarrhea. Second mechanism is defective absorption. This could be due to a resection of a portion of the small intestines, either due to tumor or trauma damage. The small intestines is where most absorption of nutrients takes place. It could also be due to diseases that damage the mucosa of the small intestines, resulting in a decreased surface area. Or enteritis, that can result in a very mild form of malabsorption. There are also some conditions that can result in defective absorptions. These include celiac sprue, also known as non-tropical sprue. This is a genetic disorder where the person is very sensitive to gluten. Gluten is a protein found in wheat, barley, and rye. Here you will see a flattening of the intestinal villi, and this ends up decreasing the absorptive surface area available. The other condition is tropical sprue. This gets its name because it is very common in the tropics. Tropical sprue, though, is due to an infection and it is not genetic in nature, but it also causes flattening of the intestinal villi. Another condition that can result in defective absorption is Crohn's disease. Here you will see loss of mucosal surface area due to the infiltration of inflammatory cells. Whipple's disease is another condition. This is a systemic infection where bacteria-filled macrophages infiltrate the mucosa. A final condition is primary intestinal lymphoma. This is a rare tumor of the intestine. The tumor spreads through the mucosa and flattens the villi. Then there are transit defects. This is a defect in the transport of nutrients via either the lymph or the blood to the systemic sites where they are needed. Any defect that compromises transit will result in a deficiency that looks like absorption never took place. Some of these conditions include Whipple's disease. Here the macrophages infiltrate the mucosa and compress its lacteals. Lacteals are special lymph vessels. Lymphangiectasia, this is when the lymph channels become narrowed or closed. In these first two conditions, they involve the lymph transport. Lymph vessels and the lacteals are very important with the transport and the absorption of lipids. So these two conditions interfere with the transit of lipids. A-beta lipoproteinemia. This is due to a lack of beta lipoproteins. Without these, chylomicrons cannot be made, and absorbed fat ends up becoming trapped in the epithelial cells. This will reduce lipid transit from the intestinal epithelium. A-beta lipoproteinemia is a genetic defect. So here's our three causes, either a faulty digestion, faulty absorption, or faulty transit. All will result in malabsorption. When malabsorption occurs, it will result in various consequences, which we are going to discuss next. One consequence of malabsorption would be a caloric deficiency. This will result in weakness, weight loss, fatigue, and anorexia. It can also result in systemic problems, such as coagulation disorders due to a lack of vitamin K, anemia due to a lack of vitamin B12, and abnormal muscle function due to a lack of calcium. Another consequence is steatorrhea. This is excess fat in the stools. This is due to a lack of uptake of the fat in the intestines. Or another cause could be due to the decreased caloric uptake. As a result of taking in less calories, one will have an increase in appetite. This tends to cause one to consume more fat-containing foods, which would then increase the amount of fat in the lumen. One can also see floating stools. These are stools that contain an increased content of low-density fat, which will cause them to float in the water. Lastly, diarrhea, due to an inadequate water absorption or due to increased particles in the lumen, which will cause the osmotic flow of water into the lumen. The last condition we will look at is obstruction. There are two types of obstruction. The first is mechanical obstruction, which is due to some sort of physical blockage. This could result from an internally obstructing mass, for example, a swallowed foreign object or possibly a colon tumor. It could be due to compression or distortion of the bowel. This may be due to herniation of a loop of the small intestines through the abdominal wall. It could be a congenital malformation causing a mechanical obstruction. It could be due to a narrowed or closed esophagus. It could be due to a congenital pyloric stenosis. This is a narrow opening to the duodenum that limits gastric emptying. It could be the result of healing complications following peritonitis or abdominal surgery. This often leads to the development of adhesions. These adhesions may end up adhering a loop of the bowel to the abdominal wall. This can form a kink that ends up narrowing the lumen. Adhesions could also be between a loop of the bowel and the abdominal wall, forming an opening through which another loop becomes trapped. Essentially, the intestines knot themselves up. Contracture of fibrosis tissue at the site of healing can produce strictures that end up obstructing the bowel. Mechanical obstruction can also result from a volvulus. This is when a loop of the intestines wraps around its supporting mesentery, and it forms a point where it twists around itself. Again, this will form an obstruction as well as compressing arteries and veins. This can lead to strangulation and necrosis. A final cause of mechanical obstruction is an intussusception. This is when a part of the small intestine becomes drawn into a distal portion of the bowel. This is usually the result of peristalsis that pulls a section backwards into the bowel. The second type of obstruction is an adynamic ileus. This involves the loss of motility in the intestines. One form is paralytic ileus. This involves a neurogenic reflex that stops the normal intestinal motility. This could be due to various abdominal stimuli such as pain, peritonitis, appendicitis, trauma, acute distension of the abdominal organs. It is also seen with systemic infection, renal disease, and electrolyte imbalances, especially imbalances of potassium. Another cause would be a vascular ileus. This is due to compromised blood supply. This can result from a thrombosis, atherosclerosis, or compression of the mesenteric vessels that supply the intestines. Some consequences of obstruction include vomiting. Vomiting is usually the response of obstruction in the upper GI tract. The vomiting reflex will be triggered by distension as food accumulates proximal to the point of obstruction. The vomiting is usually persistent and often results in fluid loss, causing dehydration, electrolyte imbalances, and loss of nutrients. Another consequence is abdominal distension. This occurs when obstruction is in the lower GI tract. The intestines become distended as food accumulates. You will also get abdominal bloating and cramping. Distension also occurs as fluids and ions are secreted into the lumen. This can suppress or compress the mesenteric vessels, causing an increased risk of ischemia and necrosis. Another consequence is colon obstruction. Stasis favors bacterial proliferation. This will increase the potential for necrosis, perforation, peritonitis, and widespread infection. Another consequence is obstipation. This is the lack of fecal or gas evacuation due to obstruction. Pain can also occur. This is due to pronounced peristaltic waves that are trying to move the contents of the lumen. And this is just showing the sequelae of obstruction.